Hello. This next series of slides will discuss how to develop as a clinician scholar. Throughout the course, we've discussed the different components of evidence-based practice. This particular presentation will describe how you can use some of those components of evidence-based practice and apply them to real-world clinical scenarios. More specifically, areas of your clinical practice that you have questions on, or areas that you might like to see improvement in. When looking at the goals of present-day healthcare and healthcare delivery methods, we know that healthcare should be safe, effective, patient-centered, timely, efficient, and equitable. Sometimes, however, there may be concerns with patient safety, or we may question the effectiveness or efficiency of our healthcare delivery methods. A practical method of looking at how we're doing in the clinic really deals with this concept of continuous quality improvement. And these continuous quality improvement initiatives really encourage all members of the healthcare team to continually ask, how are we doing? Can we do things better? Can we do things more efficiently and become more effective? And this culture of continuous quality improvement really relates back to how can we make things better for the patient, our practice, and the population in general. Continuous quality improvement begins with a critical assessment of the current state of healthcare delivery methods. Once we identify a concern in those methods, we then would integrate a continuous quality improvement initiative to make tangible changes that are going to improve patient care, improve population health, and reduce cost. While there are many models and methods that can be used to assist with continuous quality improvement initiatives, the one we'll discuss here is a model put forward by the Institute for Healthcare Improvement. It deals with first trying to get an understanding of what you're trying to accomplish, and then how will we know that a change is truly an improvement in the system, and what changes can we make that will result in improvement. Once we've looked at those questions in a critical manner, we'll then implement a process called Plan, Do, Study, and Act. The Plan, Do, Study, Act component of a continuous quality improvement initiative in many ways resembles the scientific method. For example, in the planning stages, we're going to propose a change based upon our analysis of a particular situation. We're going to propose how we're going to test it, and we're also going to develop hypotheses. In the doing component, we're going to implement our change idea, we're going to collect data, and then we're going to reflect on how well the plan was followed. In the study section, we're going to analyze the data that we've collected. We're going to compare results to our predictions and really determine if our hypotheses were supported or refuted. And then finally, in the acting stage, we're going to share our final reflections and thoughts with our colleagues, and we're going to determine if we're going to adopt, adapt, or really abandon our change idea. As I mentioned previously, there are several models for continuous quality improvement initiatives. The model that we've introduced to you is really best suited for improvement initiatives that require a gradual, incremental, and a sustained approach to quality improvement. When trying to determine areas that are important to improve upon, it's sometimes helpful to look at where we've fallen short in the past. This particular slide shows that heart disease is the #1 killer in this country, and it has been for some time now. While we have made positive strides toward improving heart disease in this country, some of our efforts have fallen short, and it is definitely an area that could be improved upon. This study, published in the Journal of the American Medical Association, attempted to estimate the amount of money that's spent on personal health care and public health according to condition, age, and gender. This slide details the personal health care spending in the United States by condition for the calendar year 2013. As we examine the slide a bit closer, we note that ischemic heart disease and the treatment of hypertension were 2 of the 4 most costly conditions in this country. As I mentioned previously, heart disease is the #1 cause of death in this country, so it is quite concerning in terms of morbidity and mortality, but it's also quite costly as well. And it's this type of condition that we can look at to determine, is there any particular methods that we can do that can help us improve how we're managing patients in heart disease. One group that has done a fair amount in the area of continuous quality improvement initiatives is the Kaiser Foundation group in Northern California. They've designed several different methods in their healthcare facilities that have really been focused on safety, effectiveness, and efficiency of care. The graphic on the bottom of your screen looks at their adult primary care clinic and how their adult primary care clinic team is really an expanded primary care team with physicians, nurse practitioners, registered nurses, physical therapists, other ancillary healthcare providers like pharmacists and clinical health educators and behavioral medicine specialists. And all of these individuals are really working together with the goal of really preventing, educating, and promoting healthy lifestyles for their members. They look to provide culturally competent care and knowledge about alternative care. They make great use of telephone visits, group visits, and their individual visits are oftentimes extremely value added for the patients. The Kaiser Group has really been quite successful in their quality improvement approach toward the management of hypertension. In 2001, they implemented a multifaceted approach to blood pressure control and quality improvement. And they really had several components of the program, including a comprehensive hypertension patient registry, quality improvement metrics with dissemination of successful practices, evidence-based practice guidelines, single pill combination therapies, and medical assistant visits for blood pressure measurement. When they initially kicked off their initiative, they determined that only about 44% of their members actually had hypertension that was within normal limits. With the implementation of their quality improvement initiative, however, over the course of about 8 years, up to 80% of their members had hypertension control, which greatly exceeded the rates in California and the national mean. This slide demonstrates the evidence-based practice guidelines and algorithms that were used by providers to help control the blood pressure of their patients. As mentioned previously, The Kaiser group was successful in improving the number of members who had blood pressure control. Over the course of the 8 years of their continuous quality improvement initiative, they increased the number of members who had hypertension control from about 43% to about 80%. One might ask what the significance of that improvement would be. I think this particular study will place that into perspective. This particular study looked at the influence of 4 cardiovascular risk factors and how the presence of those risk factors can influence morbidity and mortality. They looked at blood pressure, cholesterol level, smoking status, and diabetic status, and determined once again how those factors in total influenced outcome. This slide details the lifetime risks of fatal and non-fatal cardiovascular events among men according to the aggregate burden of the risk factors that we described previously. The researchers found that a 45-year-old man with optimal levels of those risk factors has only a 1.4% chance of having a major heart event or stroke during his remaining lifetime. That's shown by the circle on the left-hand side of the table. Contrast that with a 45-year-old man who has 2 or more major risk factors. His lifetime risk would be 49.5% for a major heart event or stroke during his remaining lifetime. That's shown by the circle on the far right-hand side of the table. And so I think that the data we see in this table provides some perspective for the importance of modifying risk factors such as hypertension in the overall morbidity and mortality of patients. In the previous slides, we've discussed the importance of screening for blood pressure and appropriately managing patients who are hypertensive. We've also shown the influence of aggressive management of cardiovascular risk factors on morbidity and mortality. With respect to physical therapy, several authors have assessed how well physical therapists assess blood pressure. And the practice of screening for individuals for blood pressure prior to physical therapy intervention is generally poor and inconsistent. The most current study by Arena et al. In 2018 showed that only about half of physical therapists believe that taking blood pressure measures are important, and about 85% do not even routinely assess for blood pressure. Perhaps more concerning is that only about 1 in 4 PTs were able to correctly identify hypertensive measures. And so the concern here is that in many cases where we're seeing patients direct access in physical therapy, a routine part of that examination should be blood pressure screening. And unfortunately, it's likely not happening. One could argue that there are likely several reasons that physical therapists should be screening blood pressure in the clinic. One of the more concerning reasons would be that it could be a contraindication to exercise as commonly prescribed in PT practice. And so we believe that by identifying blood pressure readings and potentially subsequent cardiovascular risk for each patient, the physical therapist can determine whether medical clearance or additional consultation is necessary prior to exercise intervention. In addition to hypertension, this slide also shows the other cardiovascular risk factors that are important for screening. Take a moment and review this slide and study the cardiovascular risk factors and the current thresholds associated with each of them. If we screen patients for cardiovascular risk, we can then determine their risk for a future event. Individuals who are low risk are men who are less than 45 years old or women who are less than 55 years old and have only one risk factor and no cardiovascular related symptoms. Individuals who are at moderate risk are men greater than 45 years old or women who are greater than 55 years old or have two or more risk factors that we previously mentioned. Those individuals that are high risk have known cardiovascular, pulmonary, or metabolic disease or signs and symptoms of cardiovascular disease, including chest pain, shortness of breath, mild exertion, shortness of breath at rest or with mild exertion, syncopal episodes, ankle edema, and palpitations. The significance of these risk stratifications are that individuals who are low risk and are going to perform moderate or vigorous activity in the clinic do not need to have any further screening. However, individuals who are moderate or high risk, the recommendations are that those individuals are in fact screened by a physician before moderate exercise or activity is going to take place. Based upon the last slide, some may ask what actually defines moderate intensity activities. And if you look at the chart here, we define what some of those activities are. It could be stationary cycling at a very light effort, or walking at 3 miles per hour on a treadmill, or performing light or moderate effort calisthenics. These are activities that we commonly prescribe for patients as part of our physical therapy intervention. And these are the individuals, these individuals who are moderate or high risk, that should likely, we need to make sure that they're screened appropriately before they're performing these activities. Otherwise, they could potentially be at risk for a cardiovascular event. So the reasons that physical therapists may screen blood pressure may be very different than why a physician does. It's not to say that if we screen a patient for blood pressure and they have blood pressure that's elevated, we wouldn't want to refer them back to the physician to ensure that appropriate measures are taken to get them to within normal limits. But sometimes we look at whether or not blood pressure or cardiovascular risk may be a contraindication to exercise, at least in the short term. So the purpose of this particular continuous quality improvement initiative was to assess the prevalence of cardiovascular risk factors in individuals seeking physical therapist services in an adult outpatient orthopedic setting. And to bring this back to the model we proposed earlier, our plan was to propose that blood pressure should be tested on the vast majority, if not all, of the patients in physical therapy. And we hypothesized that a fair number, perhaps 30 to 40%, would either be moderate to high risk for a cardiovascular event in an adult outpatient orthopedic setting. Our plan was to then collect data, and our data was to be collected really in a systematic approach, in that we were going to have physical therapists assess cardiovascular risk on all of our patients that came in for a consecutive manner, and then look at the data, analyze it, and really compare those results to what we predicted. Remember, one of the reasons that physical therapists don't take blood pressure is that they don't believe it's indicated for their population, or they think that there's really not any necessary reason for them to look at it, and it may not inform their management. And finally, after we do the plan, do, and study components of this improvement initiative, we're going to have to act. We're going to have to determine whether or not we truly should adopt a blood pressure screening for all patient mentality, and finally share those final reflections with not only our physical therapy colleagues, but also our physician colleagues as well, because this could potentially influence medical referrals back to primary care physicians for high blood pressure or increased cardiovascular risk if folks have that. We had to provide physical therapists with a standardized data collection form, and you see that here. This was the form that was used by physical therapists for each particular patient to determine whether or not their patients had cardiovascular risk. The second part of the form dealt with patient disposition, more specifically whether or not the patient would need to be seen by a physician for medical referral. If a patient was low risk, there was no need for them to be seen. However, if the patient was higher risk or in a moderate risk category, and we define those there for the therapists, they would need to be seen, especially if the physician was unaware of their current cardiovascular risk status. The two middle areas there where no physician referral is necessary, it really goes back to that many of these patients are already being seen by their physicians. Physicians are aware of their cardiovascular risk, and the findings that we have in physical therapy are consistent with those. So there really would be no reason necessarily to refer these folks back to physicians because they're already being managed for their cardiovascular disease appropriately. In this particular trial, 273 consecutive patients were seen, the majority of which were male, average age about 44 years, and a body mass index of 28. And patients were primarily seen for impairments related to the lower or upper extremity, as well as impairments related to the lumbar spine. This particular slide details the percentage of individuals who had each particular cardiovascular risk factor. If we look at the table, we'll see that about 1 in 4 individuals were obese, hypertensive, had dyslipidemia, or had a sedentary lifestyle. It's also important to note that about 8% of patients had active signs and symptoms of cardiovascular disease, including chest pain, shortness of breath at rest or with exertion, syncopal episodes, or palpitations. This particular slide stratifies cardiovascular risk for all of the participants in the study, as well as for the men and women who participated in the trial. It's important to note that about half of the individuals in this trial were either at high or moderate risk for a cardiovascular event. The other important point with that is that these are individuals who could potentially require screening by a physician prior to implementing moderate or vigorous physical activity. It's also important to note, if we look at the stratification based upon gender, that women were at much higher risk with respect to cardiovascular stratification than men in this trial. So in summary, according to guidelines from the American College of Sports Medicine, the majority of the patients in this particular trial were stratified as either moderate or high risk for experiencing a future cardiovascular event, and they would potentially require medical clearance before aerobic exercise or physical activity are added as a physical therapy intervention, especially if those events, those aerobic exercise and physical activity events, were classified as either being moderate or vigorous based upon the table that we described earlier. So despite about half of our patients being either moderate or high risk, only about 10% of patients in this particular study required physician referral. Part of that is that many of these patients who are already at moderate or high risk were already being managed by their physician for cardiovascular disease. It was likely that these 10% of patients either had symptoms that were new or were not reported to their physician, and that's what required physician referral. So in the end, Given the fact that half of these patients in this particular trial were at moderate or high risk for a future cardiovascular event, we believe it's important to not only look at blood pressure, but also a full, thorough cardiovascular screening. And so in conclusion, it's important that physical therapists are familiar with and implement appropriate methods to identify cardiovascular risk in their patients, as these findings could potentially influence choice of intervention and treatment outcomes. In summary, this presentation talked about ways in which you can all become clinician scholars. You don't always have to do full-blown research projects in the form of randomized controlled trials to develop as a scholar. This particular presentation talked about methods of continuous quality improvement and how those projects are important in answering very, very practical clinical questions. So I would encourage all of you to develop a philosophy that encourages you and your staff to continually ask how you're doing. Can we do things better? Can we do things more efficiently and more effective? And it really brings about a culture of improvement that really benefits the patient, your practice, and the population in general. Thank you for your attention.